Good afternoon, everyone. I, Vandita, on behalf of Hexagon Nutrition, welcome you all to the sixth webinar on the ongoing series of ISPEN webinar series. And today we have with us experts from Jaipur talking on feeding in critically ill patients, especially in diabetic patients, and what the dietitian should know. As we start, I would like to introduce our moderator for today. Just a minute. Dietitian Priti Vijay, RD. She's a head dietitian of SDMH Hospital, Jaipur. She has more than 21 years experience in clinical nutrition workspace. She's a diabetes educator, pediatric diet counselor, and a critical care nutritionist. She's a vice president of IPN Jaipur chapter. She has various achievements to her credit. She's an achieved RD registered dietitian recognition for RD training. She was the first in Rajasthan to get this recognition. She's a faculty for certificate course on advancing excellence in clinical nutrition of IIHMR Bangalore. She's also a faculty for clinical nutrition and sports nutrition for FRCC internship. Apart from this, she's written a book on nutrition and health sciences for CBSE. She has various publications in magazines and newspapers and also has presented on health and nutrition on various TV shows. She's delivered several health and nutrition related health talks in many corporates, government offices, schools, and colleges. We welcome you, ma'am, today, and I'll hand over the session to you from here on. Thank you, ma'am.
Thank you so much, Vandita, for your generous introduction. And good afternoon, everyone, and a very warm welcome in today's webinar. And we are in today's webinar, we are going to discuss about the diabetes management in the ICUs. As we all know, diabetes is a very, very big problem in the ICUs, and sometimes it's a hyperglycemia, sometimes hypoglycemia. So today we are focusing on the topic of feeding critically ill diabetics. And throughout this session, we will be exploring some important aspects, insights, practical examples, and useful takeaways that we can apply right away. It is my pleasure to introduce our speaker for today's webinar, Dr. Pankaj Anand, sir. Sir is a Director, Critical Care and Internal Medicine, Fortis Hospital, Jaipur. Sir is a President of ACE Academy of Clinical Education, past Secretary of ISCCM Jaipur Chapter, ISCCM EC Central Zone Member 2018 to 2020, and sir is having 23 years of experience in critical care in ISCCM. Sir is a member of ISCCM from since 2001. Teacher for IDCCM and Dr. NB Critical Care Courses. Examiner for IDCCM and Dr. NB courses. Faculty in national and regional conferences. Authored book chapters in various critical care books. Sir has also got the position statement of ISCCM on peripartum infections. Editorial board member in critical care communications. Membership of, sir also got the membership of Rajasthan Medical Council, RMC in 1996, Indian Society of Critical Care Medicine, Indian Medical Association, European Society of Critical Care Medicine. And his major area of interest is infections, mechanical ventilation, difficult weaning, ARDS, nutrition, and well-being. So we are honored to have you, sir, with us today. But before starting, I would like to say some suggestions that I wanted to give. Please, you all can leave your questions in the chat box, and please keep your microphone muted to avoid background noise. We will take all question answer sessions after the session. Now, without taking any more time, I would like to hand over the session to Dr. Pankaj Anand, sir. Sir, please, welcome you here.
Thank you, Preeti. It's indeed an honor to be able to join all of you people. First of all, let me congratulate ISPEN for this wonderful series of webinars you are having, and of course, Hexagon Nutrition to facilitate the entire process. Now, I'll just start these rights. Now, we as critical care people are usually so preoccupied with what we think are more important topics like hemodynamic monitoring of a critically ill patient, or the ventilator strategies, or managing the kidney dysfunctions, or more importantly managing the infections, that many a times we tend to, not voluntarily, but many a times we land up not taking the nutrition part very seriously. And this problem becomes far more severe when the patient happens to be a diabetic. And that is where our nutritionist friends can and are of great help to all of us. So, in the next whatever time, I think 30-40 minutes, I'll just touch upon what a nutritionist or a dietitian should be watching at when she visits a diabetic patient in the ICU, how she can be of immense help as a part of the team of managing these seriously ill patients. Now, my talk is basically divided into three parts. The first part is, of course, the didactic information that would be included. After that, I'll have a small case history just to highlight what can be learned from this talk. And finally, we'll have a small 8 to 10 slides, multiple choice questions based on the case, so that at least we get to know what we've learned from here. Now, feeding the critically ill diabetics, what everyone, especially the dietitians, should know. You need to understand the metabolic stress that is there in a patient who's seriously ill and admitted in the ICU, and the entire phenomenon of what is termed as dysglycemia. We'll touch upon the synchrony between nutrition and insulin inside the ICU. We'll also then try to guide the practical evidence-based facts for our day-to-day practice. Now, why this is important? Almost 30 to 40, I mean, 3 to 4 patients that are wheeled into the ICU show high blood glucose levels, and this prevalence is on the rise. Dysglycemia, the literal meaning of the word, incorporates hyper, hypo, or a variable blood glucose. It creates havoc with the system of the person, increases not just the ICU length of stay, also increases the morbidity and the chance of dying. Now, nutrition delivery significantly affects the glycemic control. The dietitian plays a central role. She decides the feed selection, the rate adjustments, and monitoring. And any poor coordination between diet and insulin ultimately leads to very serious, dangerous glucose swings, which could cost the patient his or her life. Now, any patient who comes into the ICU, there is, talking specifically about blood glucose, the problem starts with the detection of blood glucose. We then have to think about insulin infusions, the proper right nutrition and medication, continuous blood glucose assessment, and also a major killer in ICUs many times is not just a high blood glucose level, but we also have to think about managing hypoglycemia. Now, in the ICU, we play a balancing act. This balancing act is not just for the other things, but also in nutrition, you have to answer a lot of questions. Whether to give enteral nutrition or a parenteral nutrition would be fine for this patient. Should I start an early artificial nutrition or should I delay it? How do I assess this patient? Indirect calorimetry or simple predictive equations? Would a caloric nutrition be okay, or it has to be hypercaloric? Is continuous enteral nutrition perfect, or I go for intermittent enteral nutrition? So these are permanent questions that always we have to look for answers to. And Like everything in a critically ill patient, it is all at the end of the day a team game, a multidisciplinary involvement that actually brings the results right from the intensive care doctor to the nutritionist to the clinical pharmacist to the radiologist to the hospital management. Everyone has to chip in to actually bring the success that we all seek. Now, there are certain unique challenges in the ICU. It starts from the entire stress physiology drastically altering the metabolism. We all know that in a critically ill patient, there is a huge stress in the physiology, and this often leads to altering of metabolism. There is an increase in the insulin resistance, which happens within hours of the critical illness. Your kidneys, liver, and organs dysfunction, thereby changing the insulin clearance, the pain, the use of sedation, the vasopressors, that is the drugs that actually increase the blood pressure, and procedures lead to a feeding pattern which is not predictable, which is not stable. And these frequent interruptions in feeding, whether it's because of imaging, surgeries, procedures, or intolerance, ultimately affect the glucose levels. So today we will try to explain why ICU hyperglycemia behaves differently from managing patients with outpatient diabetes. We'll try to identify safe glucose targets and avoid extremes. We'll try to distinguish between intravenous and subcutaneous insulin approaches. We'll learn to adjust nutrition according to insulin needs and medication changes. We'll try to actually learn how to use fiber appropriately in a patient who's critically ill. And we'll also learn to think and to anticipate glycemic disturbances which occur because of the various drugs that are going on in a patient who's in the ICU. Now, the first question that needs an answer is why glycemic control is different in the ICU as against in the wards or in the OPD. As I said earlier, there is almost a hormonal storm that is going on in these critically ill patients. This critical illness triggers flight or fight response. So you have an increase in catecholamines, that is the flight and fight hormone, or the adrenaline and noradrenalines, and these actually increase the glucose output of the liver. There is also increased secretion of cortisol, which causes increased gluconeogenesis and also increases insulin resistance. Glucagon secretion increases, thereby causing a persistent hyperglycemia. And all these multiple factors that are triggered by stress in the ICU patient ultimately leads to even a well-controlled diabetic patient becoming unstable. Now, there are, as you all might be aware, there is a lot of inflammatory response and changes in the immunometabolism. Cytokines like interleukin 6, tissue necrosis factor alpha, CRP, all rise sharply. These interfere with the insulin receptor signaling, results in a reduction in the glucose uptake and an increase in the resistance to insulin. Also, prolonged inflammation that is very common in ICU patients ultimately causes persistent dysglycemia. Now, the acute illness induces insulin resistance by various mechanisms. The muscles become resistant to insulin just within 1 to 2 days of ICU admission. The GLUT4 translocation. Now, the GLUT4 actually causes the movement of blood sugar from blood to inside the cell. So this translocation gets impaired. So there is more sugar going on in the blood rather than going to within the cells. Hyperglycemia continues despite our giving high insulin infusion. And this entire process is a very dynamic process. If the sepsis resolves, there is an improvement in the glycemic status, which we'll talk about later. Now, how is ICU hyperglycemia different from usual diabetes? As I said, stress hyperglycemia can occur even if a patient is not diabetic. And nowadays, we use the stress hyperglycemia ratio to actually distinguish between chronic versus acute elevations. So what we do is we take a blood sugar at the time of admission to the ICU and we calculate the average blood sugar based on the glycosylated hemoglobin readings, that is HbA1c readings, and the ratio of the blood sugar to HbA1c related average blood sugar gives us the stress hyperglycemia, and this therefore helps us in distinguishing whether this increase in blood glucose is acute or this patient was a known chronic diabetic, but didn't know that he or she was suffering. And of course, an acute glucose rise has a poor prognosis compared to a relatively chronic rise. Now, we all know hyperglycemia is bad. It impairs the neutrophil function, thereby increasing the risk of infection. It delays the entire process of wound healing. It causes cellular oxidative injury. It worsens the dysfunction at the endothelial level and causes microvascular damage. And ultimately, this promotes dehydration and osmotic diuresis, resulting in increased rates of death, increased days on ventilator and in ICU, increased risk of acute kidney injury. There are higher rates of delirium, more infections, ventilator-associated pneumonias, the central line associated bloodstream infections, wound infections, all of them increase manyfold. Now, it's not just the high blood glucose that is a killer. In fact, the glycemic variability, which means that swings between high and low glucose actually have a worse prognosis than a stable high glucose. This variability of blood glucose causes oxidative stress as well as injury to the endothelium. The nutrition interruptions plus variable insulin dosing are major contributors to this glycemic variability. Now, what about hypoglycemia in the ICU? And I personally believe hypoglycemia is a much bigger killer in any patient as compared to hyperglycemia. Hypoglycemia, what we mean is a blood sugar level of less than 70 milligrams per deciliter, has a very strong association with death, occurs when, for any reason, if the feeds are held suddenly and the insulin continues, or the insulin infusion is not adjusted to the feeds, or in many cases, the patient is improving, the sepsis is resolving, the insulin sensitivity returns, but we keep on giving the same dose of insulin, and this patient lands up in hypoglycemia. And this is one area where our dietitian friends can make a major difference by having a proper dietitian-doctor communication and highlighting this possibility of hypoglycemia. So if I were to summarize this pathophysiology of dysglycemia, hyperglycemia is basically a sum of stress hormone secretions, the process of inflammation, and reduced cellular level uptake of blood glucose. Hypoglycemia usually occurs because of interruptions in feeds or excess insulin. Variability results in rapid shift because of rapid shifts in feeding and medications. And unfortunately, whether it's hyperglycemia, hypoglycemia, and variability, all of these three contribute to poorer outcomes in ICU patients. Now, then what should be the ideal glucose targets in the ICU? This slide. The guidelines say the American Diabetic Association guidelines 2024 give a value of around 140 to 180 milligrams per deciliter. The surviving sepsis guidelines also give a value of 140 to 180 milligram per deciliter. Now, you'll appreciate that you might feel that 140 is too high, but there is this big, very important trial which actually has changed the way we practice glycemic control in ICU, where it has been clearly proven and recommended that we should avoid strict blood sugar control in very critically ill patients. Actually, the AACE, the American Association of Clinical Endocrinologists and the Endocrine Society, recommends individualization of blood sugar targets for a special population. As I said, safe glucose targets recommended by most ICU patients, for most ICU patients, is 140 to 180. The benefits being there are lower risks of hypoglycemia, there is reduction in the variability in blood glucose levels, and this basically balances safety as well as efficacy. Now, what happened? Why tight control failed? The nice sugar study actually fixed a target of around 80 to 110 milligrams per deciliter, and they realized that the mortality or the death rate suddenly increased in this patient. This happened because of very high rate of severe hypoglycemia when we tried to control the blood sugar very tightly. ICU nutrition interruptions make tight control unsafe, and insulin sensitivity swings widely especially when the patient is recovering from shock. Now, while hypoglycemia is dangerous, hyperglycemia is also pretty dangerous. And when I say hyperglycemia, I mean a blood sugar level of more than 180 to 200 milligrams per deciliter. As I said earlier, high blood glucose promotes infection and inflammation. It causes osmotic diuresis, ultimately leading to dehydration. There are higher risks of ketoacidosis in type 1 diabetics. The immune system becomes impaired. The wound healing becomes poorer. Now, how does our nutrition affect these targets? Of course, a continuous feeding is ideal where it keeps the blood sugar far more stable. We can give bolus. The bolus feeds actually cause increase in blood sugar, and there's a risk of post-feed hypoglycemia. Feed interruptions usually lead to insulin mismatch and chances of hypoglycemia. The carbohydrate percentage determines insulin requirements, and the protein-only feeds have minimal glycemic impact. So if you look at the practical target summary, aim for a blood sugar level of 140 to 180 milligram per deciliter for most ICU patients. You could have slightly higher or targets if the patient is a patient of a neurological disorder or post-operative cardiac patient. Loser target, especially for severe comorbidities, hypoglycemia-prone patients, but always keep this in mind, always reevaluate, especially when the patient is improving and is transiting from shock to recovery, because this is where the chances of hypoglycemia are higher. Now, something that you should know about insulin in the ICU. Why all of us intensivists prefer intravenous insulin? You could give insulin intravenous or you could give insulin subcutaneous. Intravenous is preferred in a critical ill patient because, of course, it has a rapider onset as well as offset. It is very easily titratable hourly, works even with poor peripheral perfusion. It is safer when feeds are unstable. And of course, it is mandatory in a patient with diabetic ketoacidosis or a patient of hyperosmolar hyperglycemic state, patient of shock, or a patient who has a multi-organ failure. So ICU IV insulin is indicated in sepsis and septic shock, patient on vasopressors, DK and HHS, post-cardiac surgery, organ transplant ICUs, or in a patient where there are dramatically fluctuating feed rates. Now, you could make subcutaneous insulin acceptable if your patient is hemodynamically stable, is on predictable continuous enteral feeding, if the respiratory mechanics are stable, if the patient is not transiting from ICU to the ward, or long-term enteral tube feeding is possible without interruptions. But trust me, In majority of patients who are critically ill, this is not the situation, and therefore most of these patients are and will be on intravenous insulin. Now, you must have heard and seen the concept of sliding scale. A sliding scale is basically correctional insulin. So it is not or never to be used alone in ICU. It should basically supplement basal nutritional insulin and is used to correct unexpected hyperglycemia. So it actually reflects a reactive way of treating rather than a proactive treatment and is not very much favored in most people. So what is this basal bolus correction model? Now, a patient who is sick and we want to manage sugar, you give a long-acting insulin, which is termed as the basal insulin. Usually, it starts functioning in 1 to 1.5 hours. Action lasts for 18 to 20 hours, and it covers the fasting needs that you and I and every patient needs. Then there is the nutritional insulin, which you give whenever you feed the patient. So it matches the carbohydrate load from the feeds. If the carbohydrate is high, you give higher insulin. If it is low, you give lower insulin. And correctional doses, what are also termed as the sliding scale, manages any unexpected rise. Now, this is best for subcutaneous insulin in stable ICU patients, but not on patients who are on IV insulin. Now, coming to feed changes and insulin adjustment, of course, an increase in feed rate, you have to increase the insulin infusion. If there is a sudden feed interruption, you immediately reduce insulin rate. If the patient is undergoing procedures or there is dislodgement of the tube, then these are high risk times. You have to be very cautious. This is the time when dietitians must notify the team before they modify feeds. So if you're suddenly increasing a feed in a patient or suddenly reducing a feed in the patient, please inform the treating physician because they then have to modulate the insulin accordingly. Now, what about the parenteral nutrition considerations? PN typically is high in dextrose, thereby increasing the risk of hyperglycemia. Insulin can be added to parenteral nutrition bag or given separately. Avoid large dextrose boluses. Start parenteral nutrition slowly in diabetics and monitor every 4 hours initially. Common pitfalls when we talk about insulin. Insulin, you could be continuing insulin while feeds are held, causing a catastrophic severe hypoglycemia. You could be under-recognizing the steroid-related glucose peaks and causing hyperglycemia on these patients. You could be doing inconsistent glucose monitoring. The bolus feed in unstable patients could lead to spiking, or you might not have adjusted insulin when sepsis resolves, as I said earlier, leading to hypoglycemia. So remember, IV insulin is the safest for a patient who's unstable in the ICU. Subcutaneous insulin is for patients who are stable and have more predictable feeding. Feeding insulin coordination is essential, and the dietitian input is crucial in preventing hypoglycemia. Okay, friends, now let us briefly touch upon what is the role of fiber in the nutrition of a patient, especially in the ICU. We know that in diabetics, fiber slows carbohydrate absorption, it improves satiety, it reduces the spikes of blood glucose. But remember, the physiology in the ICU is very different. There are two types of fibers, you all know, soluble versus insoluble. The soluble fiber usually forms gel, it slows the glucose absorption. The insoluble fiber increases the stool bulk, therefore causing increasing the risk of bowel distension. So the preference in ICU is of course the soluble fiber. Now, if you look at the fiber in ICU formulas, the standard diabetic formulas include moderate soluble fiber, which is definitely better for patients who have diarrhea, but should ideally be avoided in hemodynamic unstable patient. It is poorly tolerated in bowel edema or ileus. The fiber is not indicated if your patient is on high vasopressor doses, if you are suspecting bowel ischemia, if there is severe abdominal distension, or severe ileus or gastrointestinal mortality. Yes, fiber is useful. If your patient has an antibiotic associated diarrhea, if the patient is stable patient on full enteral feed, if there is no risk of ischemia, and here the soluble fiber is preferred over insoluble fiber. Now, while we are talking about sugar in a patient who's in the ICU, besides the stress, besides insulin, besides what we are feeding the patient, another thing that has a huge impact on the blood glucose levels in the ICU patients are the various medications that are being given to these patients. So I'll just touch upon 3 or 4 of them. Steroid is something that is very commonly used in a patient who's dying because of a critical illness. And steroids, by their very nature, increase the secretion of the basal insulin. So for these, they also add nutrition. You need to add nutritional insulin for day feeds. For ICU insulin, you have to increase rate around the time of steroid peak, and you need to be very, very cautious while monitoring blood glucose. They say 4 to 6 hours. I would say 2 hourly you should do for patient who's on steroids, especially on intravenous steroids. Another drug that I want to talk about, most commonly used drugs in the ICU are the vasopressors. You must have seen the adrenalins and the noradrenalins and the vasopressins. These are catecholamines, and they, by their basic nature, as I've also pointed out in the initial slides, increase glucose production. They reduce the perfusion of the gut, and there are high doses. Actually, when the patient is on high doses of catecholamines, there is contraindication to fiber, and these patients also need pretty high levels of insulin to stabilize their blood glucose. Now, beta blockers are another group of drugs that are many a times used in the ICU, and by their very pharmacological nature, they tend to mask any symptoms of hypoglycemia. But it is therefore where they become dangerous. If your patient is on beta blocker in the ICU or even otherwise, always remember that the hypoglycemia signs, the sweating, the tachycardia, the ghabrahat will not be there in a patient who is hypoglycemic. So the chances of hypoglycemia are much higher in a insulin-treated patient on beta blocker. And this is particularly important in the cardiac ICUs where a large number of patients are on beta blocker to actually manage their heart rates. Now, the many other medications affect glucose, but some that are more used in ICU. Thiazide diuretics, they tend to increase the blood glucose levels. Patients on statins, whether it is atorvastatin, rosuvastatin, they will have a mild increase in glucose. Drugs that are used in the post-transplant ICUs, drugs like tacrolimus, cyclosporin, they are known to cause hyperglycemia. And patients who are on antipsychotics, the antipsychotics increase their insulin resistance, thereby making them liable to high blood glucose levels. Now, something that we forget about is the sugar in liquid medication. Usually, you will not find a lot of patients on liquid medication in the ICU, but still, many syrups you all know contain sucrose or sorbitol. Steroid suspensions also are sugar rich, and these could contribute significantly to the spikes in blood glucose levels. So I would suggest always prefer IV drugs in the ICU whenever it's possible, so that you are not actually introducing sugar in liquid medications without actually being aware of it. So medication summaries, remember steroids cause predictable glucose rise. So you need to monitor your insulin infusions as per your steroid spiking. Vasopressors increase blood glucose by stress hyperglycemia and hypoperfusion of the gut. Sugary medications have act as hidden carbohydrate sources, and we need to adjust insulin by anticipating any such changes happening because of medications. Now, a couple of slides on some practical nutritional strategies on managing blood glucose in ICU patients. Which enteral formula to choose? I would say diabetic formulas, which have moderate carbohydrates, higher proteins with soluble fibers. Of course, you need to avoid a formula with fiber if your patient is very sick, is on high doses of uh, vasopressors. And usually, when the patient is on vasopressors, we are not giving oral feeds anyway. Avoid very high fat formulas in shock or organ dysfunction. Uh, Aim for stable carbohydrate delivery in these patients while choosing the enteral formula. Now, how do you coordinate nutrition with insulin therapy? Always communicate before you make any change in the feed. So, if you are reducing, stopping, increasing, changing the feed, talk with the treating physician, because it's your coordination that will not just manage the blood glucose of this patient, will also help this patient come out of the critical situation. Friends, we are all a team. So nobody should carry an ego, and neither should we be scared of talking to each other. Secondly, avoid bolus feeds if your patient is unstable. Document every feed hold. This is very, very important. So because of an X-ray, a CT scan, or any procedure, if a feed is being withheld, please write it down. Ensure insulin adjustments match feed interruptions. Again, we have discussed this at length. This will prevent a lot of hypoglycemia related morbidity. And as I said, multidisciplinary approach is the key of managing a seriously ill patient. So if you look at the algorithm for diabetic ICU patients, always assess the hemodynamics and medications. Choose a formula feed. It should largely be a diabetic. You could also have a standard feed. Start continuous feeding if possible. Start IV insulin or subcutaneous insulin depending on stability. Monitor glucose 1 to 4 hourly. Adjust insulin for any feed changes and reassess as frequently as possible, at least once or twice a day. So to conclude, ICU glycemic management is unique, as I said, because this is a state of high stress and there is a hormonal storm. Dietitians play a vital role in stabilizing glucose. Please avoid extremes. Keep an aim of blood glucose in the ICU between 140 to 180 milligrams per deciliter. Understand how the feeds interact with insulin. Fiber ideally must be individualized depending on the patient's clinical condition. ICU medications significantly alter glycemic control, so please anticipate any changes in the blood glucose depending on the medication that you're giving. And safe feeding is a product of teamwork between dietitians, nurses, and the treating physicians. So this brings me at the end of the didactic section. I hope and I pray that I have been of some use. You learned something new. So let us now have a small case presentation and see how we can apply this theory that we've learned over the last 40 minutes. So this was a 62-year-old gentleman, was a diabetic, type 2 diabetic for the past 12 years. He was obese with a body mass index of 31, was hypertensive, had dyslipidemia, had diabetic neuropathy, was on home medications, namely metformin, glargine insulin, which is the basal insulin, 14 units, and glimepiride, and his HbA1c was 8.4%. Rameshji was admitted in the ICU with a severe pneumonia, sepsis, respiratory failure, was put on a ventilator upon arrival. He was on norepinephrine support. His blood glucose was 298. He was started on antibiotics and IV steroids. Now, can you think why the blood glucose was high? So we'll have MCQ sessions after this. The key message here is, in a critically ill patients, be prepared for handling hyperglycemia even before your nutrition starts. For obvious reasons, the stress hormones are high and these patients will have increased blood glucose. Now, day one, his blood glucose is 240 to 320. As I said, it could be because of stress hormones, inflammatory cytokines, steroids, and vasopressors. So he was started on IV insulin infusion. So nutrition, remember, is not the only driver of ICU hyperglycemia. Now, day two, as we all know, the right practice is to start enteral feeds as soon as possible. So he was started on polymeric formula at the rate of 1 kilocalorie per ml, titrated from 20 to 60 ml per hour, and the blood glucose suddenly increased to 280 to 350 milligram per deciliter, and we needed much higher insulin infusion. So friends, remember, even a small feed change in a critically ill patient could drastically affect the glucose. So while you are taking the rounds of the hospital, especially once you enter the doors of the ICUs, you need to be very alert with all your actions. This could mean recovery or catastrophe to the patient if you are even slightly casual. Now, we thought about starting a diabetic fiber-enriched formula, but we examined the abdomen and realized that this patient had a borderline ileus. So we moved to a non-fiber formula, because just reminding you that fiber is beneficial only when the gastrointestinal tract is stable. Otherwise, this is not recommended. Now, the clinical conditions deteriorated. We had to increase, almost double the dose of steroid, and the blood glucose suddenly went through the roof, and we had to double the insulin infusion rate. So whenever there is a patient who is on steroid, anticipate and preempt any steroid-induced hyperglycemias. Now, this patient had a high gastric reserve volume of around 180 by 220. So we had to reduce the feed from 60 to 30. And this caused the variability in the glucose to worsen. This is where you should think about titrating slowly, early monitoring, and if needed, using prokinetic drugs. Fortunately, because of the proper coordination between the physician, the nurses, and the dietitian, we were able to wean this patient off vasopressors, the steroids were tapered, and the insulin infusion requirements fell significantly. So always, this is the time when you have to be extra cautious. This is the time when all of us tend to be casual, but you have to be extra cautious. This is the time when the patient is improving, and if you are not reducing the insulin, the patient could land up in hypoglycemia and could actually worsen whatever benefits or whatever gains that we have had against the disease. So transition to subcutaneous insulin, the feeds are stable at goal. So we start with the basal plus 6-hourly scheduled insulin plus the sliding scale. The blood glucose is stable at 150 by 80. The patient is extubated day 9. Oral diet, day 11, discharge with nutrition and diabetic education. The family is happy. You get a full box full of very tasty sweets, increasing your blood glucose, but the patient is happy. So what we've learned here, remember that the nutrition-insulin interplay is a dynamic interplay. It keeps on changing every day, every shift, every hour. Steroids and sepsis worsen hyperglycemia. Fiber needs to be individualized. Feed interruptions are responsible for major blood glucose swings, and it is vital that the dietitian is always involved, thereby changing the outcome in terms of the patients. Now, this is the time for some brainstorming. I think I've given you enough clues. We'll now have some MCQs. Let's see if you are able to answer. And this is purely on this case itself. So in the first 24 hours, the patient has blood glucose of 240 by 320 despite being nothing by oral. What do you think is the most likely cause? Is it excess carbohydrate stores? Is it stress hormone surge and cytokine driven insulin resistance? Is it feed residue from prior meals? Or it is just low circulating insulin levels from dehydration? I want you to answer, please. Vote for this. A, B, C, or D. First 24 hours, sugar is pretty high. Patient is still NPO. What is the likely cause? Preeti, you need to monitor this. Are we getting the right answers here?
Miss Vanika has write down the B, and I got the answer of Yamuna has said the A. Only 2% has responded.
There are, I think, 80 people on 81 people. Please do try.
Yes,
This is
sir.
not an examination. I have taught you this. First 24 hours, why is there a sudden high blood glucose in a critically ill patient, even though you are not feeding the patient in the first 24 hours? Is it because of excess carbohydrate stores that the patient is there? Or there is stress hormone surge or cytokine driven insulin resistance, feed residue from previous meals, or low circulating insulin?
Sir, majorly are saying B.
Yes, the right answer is that the stress hormones that get released because of the stress of the disease, as well as the insulin resistance that develops because of the cytokines that are released because of the disease, they are responsible for rise in blood glucose, even if the patient is not being fed. Now, second question, on starting enteral feeds, the blood glucose rises sharply. What should be your priority as a dietitian? A, should you stop all feeds immediately, or you should switch to bolus feeding, or you should actually assess carbohydrate load and coordinate with the insulin team, or you should reduce protein to decrease gluconeogenesis? Please read the question properly and answer. So you have started the enteral feed, sugar is increasing. Now, as a dietitian, what will you do? You'll stop all feeds immediately, or you'll
No.
switch to bolus feeding, or you'll in fact assess the load of the carbohydrate and you'll coordinate with the insulin team, make changes in the insulin, or you'll reduce the protein to decrease the process of gluconeogenesis.
The major answer is that I am getting the
You mean switching to bolus feeding?
answer is C.
So the real answer is C. So
Yes, sir.
always assess how much carbohydrate is going in and what coordinate with the insulin team and change your insulin secretion. Question 3, why should fiber enriched formula be avoided in a critically ill patient? Is it A, poor glycemic control, or the patient is already receiving insulin and the fiber interrupts with the insulin, or there is a borderline ileus increasing the risk of intolerance, or there is high protein load? So we are talking about our patient. This patient, you remember, we did not start a fiber enriched formula. What was the reason? Was it poor glycemic control, patient on insulin, or the patient has a borderline ileus, which most of our patients have who are very sick, or high protein load? Please answer. Preeti
Sir,
answers.
I'm getting the answers. Yes, yes, sir, people. Or they are responding. Sir, they are writing the C answer.
C is the right answer. Fibers tend to worsen ileus and abdominal distension, so they should be avoided if your patient has a borderline ileus. Question 4. Now, if you remember the case, the steroids were increased. Which change is the most appropriate to manage the blood glucose if you are increasing steroids? You reduce the feeds temporarily, or you increase water flushes, or you anticipate higher insulin requirements and proactively adjust the insulin levels, or you switch to a parenteral nutrition. I think this should be easy. If you've been attentive in the last half an hour, so you are increasing the steroid, what should you do? Will you reduce the feeds temporarily, saying sugar is going to go up, why should I? Or you increase the flushes of water or whatever reasons you have, or you anticipate that this patient will have higher insulin requirement and you proactively adjust your insulin level infusion, or you switch to a parenteral nutrition. What are the answers?
Sorry. Sir, I got the answer of C.
So this is easy. Anticipate a higher insulin requirement and proactively adjust. A couple of questions so more, then we'll come to your answer. For continuous enteral feed, which insulin regimen is best? Is it mealtime insulin before breakfast, lunch, and dinner? Or a single daily basal insulin? Or basal plus scheduled 6-hour nutritional insulin plus correction doses? Or sliding scale alone? Should I repeat? If your patient is on continuous enteral feeds, which insulin regimen is best? Mealtime insulin before breakfast, lunch, dinner, single daily basal insulin. I think I'm being unjust. I'm asking for insulin instead of nutrition with dietitians, but still, I've taught you. So, what is the answer? Anyone?
Sir, everybody got understood what you were teaching us, and I got the answer also that they are saying about the C.
Yes,
Basal plus
absolutely
scheduled.
right. Basal plus scheduled 6-hourly nutritional insulin and correction doses. I think you could be teaching the doctors what eating. Many of them do not know all this. Now, finally, two questions more. When feeds are interrupted frequently, say for example, when there is frequent suctioning or proning, the risk is hyperkalemia, glucose variability plus hypoglycemia, severe lactic acidosis, and loss of gut integrity only. This is a very easy answer. Everyone should be knowing this. So if you are interrupting feeds frequently, what is the biggest risk? Yes. You don't have to think. You are very
Sir,
intelligent.
I think the answer is B.
Yes. The glucose becomes variable and there are increased chances of hypoglycemia. Now, what is the most important role of the dietitian in our case? Is it that's a give up. Determining IV fluids, coordinating carbohydrate load with insulin adjustments, prescribing insulin, or you could be managing the ventilator settings. So everyone knows the
Exactly.
answer is coordinating carbohydrate loads with insulin development. Friends, you have been very
Yes, sir.
patient and you have listened to all this for almost now what is 55 minutes of patient listening. Normal human brain is active only for 40 minutes, especially in the postprandial state that all of you are. So a big thank you, and I think we can take a few questions, Preeti.
Yes, sir. And thank you so much, sir, for very detailed and very insightful presentation. And I hope it really helps us in our daily practice because we are going to the ICUs and at all the time the sugars are very high, stop feed, patient is no, in a hypoglycemia, give sugar. So these are the daily challenges that we all are facing. So, but sir, here in the chat box, I have three questions. So first we can take these questions, if you allow
Mhm.
me.
Yes, yes, please do.
The So the first question is how soluble fiber helps in opioid-induced constipation?
Oh, how soluble fiber helps in opioid-induced constipation.
Cancer, trauma, neuro patients.
Okay. I mean, the topic I would have appreciated if we were talking about the ICU glycemia patient, but since you asked the question, you have to understand how opioids cause constipation. Opioids act at certain parts of our enteral tract, our intestines. There are certain receptors, and they tend to slow the movement of the intestines. There is a continuous movement from the oral to the epidural end, and the opioids tend to slow down the gastric or the intestinal motility. Now, whenever you give fiber, the fiber naturally improves the motility. It smoothens up the stuff, and thereby it tends to improve the constipation related to opioids, especially in cancer and other patients. So if I were to talk about what nutrition is right for patient of a cancer, let's forget about the nutrition things, and that we can discuss later. But talking especially of constipation, then you have to give them practical solutions. As you rightly said, that giving more of fiber, you can give more fruits if the sugar is not an issue. And I personally give to my patients a lot of that isabgol husk is pretty useful. Give it with some warm water or warm milk, and that solves the problem a lot. And this is not just the problem of the cancer patient. Geriatrics, we all have seen the movie Piku. Geriatrics is a major issue with the constipation. So you have to keep that in mind. Chilke wali dal, and all that you guys know much better than what the fiber thing.
And the second question is that does lactulose or PAC can lead to volume shifts in the patients who are critically ill patients? How to handle this situation?
Okay. So lactulose, you know pretty well the mechanism of action is it is a osmotic laxative, right? So basically it absorbs water from the intestinal tract and then makes the stool liquid and passes it out. So it is an excellent laxative because it is a non-habit forming laxative, probably the most commonly used in modern medicine. But it is not indicated in a very critically sick patient who's in the ICU because it could lead to large loss of large volumes of fluid from the system. And volume or fluid is something that is very, very important in the initial 3-4 hours of patient's resuscitation. So I usually do not recommend giving lactulose in a very sick patient.
Thank you, sir. And you have explained about the fiber, but I have the next question on the fiber only. So can you please elaborate on fiber use should be individualized with examples?
Okay, I've just said you have to individualize. And since the ambit of this talk is managing blood sugar in a critically ill patient, fiber is excellent. Fiber is excellent in most of our patients. But except for if your patient is very critically ill, if your patient has an issue with his intestine, what happens is if a patient is very sick, the blood pressure is low, the perfusion of blood in the entire body tissue goes down, right? Now, what Mother Nature has done is that if you have limited amount of blood in the body, it preferably gives to the organs which them need them, which are vital to stay alive. So your brain would be receiving blood, your heart will be receiving blood. These are and your kidneys will be receiving blood. While your gut, your skin, these are the organs where the blood perfusion is reduced because understand you have limited amount of perfusion available. So if a patient who's very sick, there are almost in all these patients, in a patient in shock, the chances of intestinal ileus. Ileus means the movement of the intestine is not desirable. So they have a chances of ileus. And now you are feeding fiber to this patient, but the gut is not moving. So this will lead to flatulence. This will lead to abdominal distension. Now, abdominal distension in a very severely ill patient, especially one who's struggling to breathe, his abdomen is distended, the diaphragm doesn't go down while breathing, and this patient's respiratory distress will increase. So, if a patient is very sick, sick enough to need medicines to increase his or her blood pressure artificially, you do not give fiber to such a patient. Yes, if your patient is stable, is having stable feeds, definitely you should give fiber, especially it is very good for diabetic patients. So, individualization is the key.
Thank you, sir. But one question, I also have few questions in my mind. So, sir, what are generally the diabetic patients, because when they are not getting the feeds for a long time because of the hyperglycemia, because sometimes they are not in a good condition. So, what are the early signs of refeeding syndrome? Because generally we heard about this word, the refeeding syndrome. So, what are the early signs of refeeding syndrome in long-standing uncontrolled diabetics?
Right, that's a good question. Refeeding syndrome, you have to understand what it is. A patient who has a long-standing uncontrolled diabetes is in a state of malnutrition. So this is a chronic malnutrition. There is osmotic diuresis happening. So these patients are volume depleted and they don't have much of intracellular storage. So these patients, when you suddenly start feeding them, there are large shifts in their body. So the first signs are the electrolyte imbalances. The first thing that goes awry is your phosphates tend to go down. Your potassium tends to go down. Your magnesium tends to go down, and this happens within 24 hours. So if a patient who has an HbA1c of 12, 13 comes to your ICU and you start feeding meticulously, keep a watch on the potassium, keep a watch on magnesium, keep a watch on the phosphate. This could be the first warning sign, red herring, for a refeeding syndrome. Ultimately, all these could lead to new muscle weaknesses happening, arrhythmias, tachycardias. The patient could go into delirium. The patient could have generalized edema. There could be large fluid shifts leading to respiratory distress. So, and ultimately, this could lead to severe hyperglycemia. So, these are the first few signs, of course, are the electrolyte imbalances, which needs to be watched and managed aggressively.
And then sometime whenever we are having the uncontrolled diabetes patient, and generally what we have seen, a patient with uncontrolled diabetes and sepsis has severe volume intolerance. And so what do you prioritize? Glycemic control or protein adequacy first?
This entire talk, I've talked about glycemic management. Hyperglycemia is a bigger killer. So, if a patient who is uncontrolled diabetes comes to you, probably has had a protein deficit for a pretty long time. So, first thing that I have to manage is the glycemia. So, I will do everything possible to bring the sugar to around maximum 180 milligram per deciliter. So stabilization of glycemic control is vital, but that does not mean I don't think about protein. After having controlled the blood glucose, that is when I will talk about protein. So I will give, you can say, a high protein, low volume formula I will use, and I'll try to stabilize the glucose first and then escalate the protein. We could use energy dense diabetes specific feeds which have pretty high proteins, which have your monounsaturated fatty acids as sources of energy. These are the ones, but always the glucose first and then the protein.
Then the protein. Okay. And so the last question. So what should the dietitian priorities be when shifting a diabetic patient from ICU feeds to oral diets?
So we are
So
talking about
generally, whenever we start eating right, then patient
I,
eats very less.
hmm.
And sometimes we have, so what do you prefer? What's your opinion on that?
We're talking about a diabetic patient. The first priority is to maintain the glycemic stability, right? And that you could choose a low glycemic index, fiber rich diet. So that, because now if you're shifting from the ICU to the ward, that means the patient is clinically relatively stable, is on stable feeds. So you can play around with the feeds. You give a low GI glycemic index food which is protein rich and maintain the glucose first. Second, you have to maintain the protein adequacy. So I would say around 1.2 to 1.5 grams per kilogram of protein. You guys know very well how to increase it. You could use your modular for things like casein based or whey based. you could go, because now this patient is relatively stable. But match the intake to the patient's capability to tolerate. That is very important. So many a times we are over enthusiastic and we tend to, forget that this patient is not in a position to tolerate sudden increase. So with what is the GI tolerability is very important. This is where a lot of time we induce diarrhea and volume loss and the patient comes back from the ward to the ICU. Keep that in mind. So proper GI intolerance has to be kept in mind. And probably the most important point, because now the patient has moved from the ICU to the ward, we tend to be casual. What is needed is close monitoring. So since we have the advantage of the patient's attendants being available in the room or ward, so please counsel them what to look for, what to, the nurse is busy, so they should actually be involved in feeding the patient. Teach them that this is the powder, you need to mix it. We will try to give it, but you should also see to it that it is delivered on time and is adequate. If the patient is not tolerating feeds, please tell me and you change accordingly. So the entire process of medicine is an interactive, ever-changing, dynamic process. Keep that in mind. It's not just writing a prescription, whether it's for a doctor, a nurse, or a dietitian. That is vital.
Right, sir. Absolutely right. Thank you, sir. Thank you so much for clearing all doubts of all of us. And really, it was a very knowledgeable session. And as we have come to the end of this session, and first of all, I would like all the participants to switch on the camera so that we can click the picture. Vandita, can we click the picture for all the
No, ma'am,
participants?
actually, it's a webinar platform, so the attendees can't this thing. Otherwise, they are not allowed actually. Ma'am, we can't have
Okay,
photos
okay.
actually that way.
Okay, okay, no issues.
Yeah.
So I would like to express my heartfelt gratitude to our speaker for sharing his knowledge with us. And a big thank you to all the participants for joining and engaging with us today. And I really appreciate your time and interest and hope to see you again in upcoming sessions. Thank you once again. Have a great day ahead. Thank
Thank you,
you.
Preeti. Thank you, Vandita. Thank you, Hexagon. And most importantly, thank you, ISPEN, for doing this splendid job. Have a
Yes.
great day.
Yeah.
Bye.
Thank you, everyone. Thank you, experts, for joining us today. And so it was a wonderful session. I think it was with a lot of clarity and a lot of basics you discussed. So I think it was a wonderful session. Thank you, Preeti ma'am, for moderating the
Very
session
well
so well.
explained by sir.
Yeah, no,
Very
but moderating it
deeply.
all also was, yes.
Yes,
So
yes, it's
thank
a
you.
very deeply sir has taken this topic very well and
Yes,
all the points covered very well. Very
yes.
basic things.
Yeah, and
Thank
it's
you.
the connecting the dots basically. So I think it was a wonderful
Right.
session. So thank you so
Thank
much.
you.
And yes, we meet again next month for the next series in this session. So thank you all participants for joining us today. And thank you, sir and ma'am, again. Thank you.
Thanks.